Good morning. Whoa, it is on. Bienvenue. Welcome to day 2. My name is Chris Simpson. I'm the president of the CMA, and we're doing things slightly out of order this morning to accommodate a necessary airport departure for one of our speakers. So bear with us. We're going to start with a presentation entitled Clinical Interventions on the Social Determinants of Health, Experiences in Slovenia. And I'd like to introduce our speaker, Assistant Professor Danica Rotar-Pavlič from the Slovenian Medical Association. She's the current president of the Slovenian Association of Family Doctors and vice chair of the European Forum for Primary Care. She's a specialist in family medicine with a particular focus on the care of older people and teaches in the Department of Family Medicine, University of Ljubljana. Welcome.
Dear Mr. Chairman, distinguished guests, dear Professor Sir Marmot, I would like to thank you to have the honor to be able to speak in front of such eminent participants. You have heard that I'm coming from Slovenia, where in addition to be president of Slovenian Association of Family Physicians, I'm also working in everyday practice, GP practice in Ljubljana. And I would like to share my experiences and experiences of Slovenian Medical Association with you. To warm up this session, I would like to start with John's story. We usually need warming before discussion, so I think it will be quite appropriate to share this experiment with you. Yeah, this is without pictures, that's the wrong presentation, but anyhow, I wanted also to show you the drawings which John made. The presentation is for web, but you will see perhaps. So John is quite capable to draw pictures, and nobody found out this capability. So we just know that 30 years John visits GP for certificate, which he needs to provide to the Center for Social Care, a sort of sick note. And only with this certificate, which contains a description of his health status, he will be allowed to receive financial support. And he rarely visits his GPs on the other doctors. He has not taken any medication for his schizophrenia for 2 years. He stopped seeing his psychiatrist because the shrink doesn't have enough sympathy for his problems. Here on the right-hand side, you should see his drawings, but I'm sad it's not possible. He prefers to cook, that's also very nice. He said to me that he studied concepts of healthy lifestyle over the internet, and he loves drawing. He lives with his parents, who have both become unemployed during recession 2 years ago. The family denies John's illness, and his father believes that he's lazy and he should work. And during a visit at the GP practice, the nurse finds that John doesn't have basic health insurance. Let's look at John's social determinants of health. I'm aware that you all know a WHO definition, so I will not repeat it. But if we go step by step, first we can say that healthcare and accessibility, he can access to GP in a simple way, but he chooses very episodically. Access to psychiatry is difficult. He would have to wait for 3 months, for example, after calling the office. And at that time, he decides usually not to go. He changed his decision. Regarding health behaviors, he stopped taking medicines, as you could hear 2 years ago, but he's exercising every day. Physical environment is still solid, but there will appear problems since parents are now unemployed. And socioeconomic factors, he didn't finish secondary school, he's unemployed, he's uninsured, and his family members are burned out. Social support is limited. He is living in an isolation from the community, and he's not attending supportive groups for self-help. So yes, there is much to say, but in fact, none of the professionals made a step forward and start with interprofessional collaboration. Therefore, all efforts are only a tiny stone in the sea. Yet we can say that the local clinic, local GP practice helps John to maintain hope. So how can primary healthcare team help John in effect? In Slovenia, during recession, pro bono practices were established, where doctors of different specialties can work for pro bono for uninsured patients. I think Greece also have such kind of practices. And one of these practices received an honorary medal of the city of Ljubljana. But we think that pro bono practices don't represent an efficient solution for people without insurance. So what can Slovenian Medical Association tell you and offer you as an examples of good practice? We did the research in the period of recession about accessibility, which was difficult even for to get the primary care doctor in some way. So we found that 14% of patients or visitors of primary healthcare practices made delays and waited to be insured again. So that was our result. But as it was presented yesterday, doctors readaptate their practices, so they offered also help for nothing, I mean, without insurance. The doctors were doing perhaps even better. They accepted uninsured patients. Then we are conducting, so yesterday, 2 ladies asked about Roma and travelers community. We had and are still running interventional project in Roma community in the northeast of Slovenia. First, we start with health literacy in this group of people, and we prepared vocabulary in their language regarding words which are usually used in primary care teams, practices, and so on. Because we found the health literacy and improving it, it's essential for education. After that, we moved to their villages, and we were having educational workshops, a sort of them, about COPD, which is quite prevalent status in this community, about diabetes, they had a lot of it, and smoking and so on. And of course, after finishing first year, we evaluated the progress, and we found that in this Roma community, they knew more about health problems. The educational part was better, but they didn't change, they didn't make lifestyle changes. We suppose that because we still have to continue with educating and conversations in that community. On the other hand, we received phone calls from the south of Slovenia, from Romani group, from there, and they asked to come there with this project too. Also, we are having a sort of Doctor of the Year medal, where doctors, we name one example of excellence, And this year we had one GP from a remote rural area, and we wanted to support this rurality and places where doctors are not so frequent. Also, we introduced social determinants of health in vocational training. So all the doctors, specialists of family medicine, have to pass this module. We name it module. And we have just finalized the booklet for teams in primary care about social determinants of health and their inclusion in everyday work. So that's are the things that we can offer. But on the other side, I would like to underline that discussions are running on and on, especially with young doctors. They ask us about definition of normality, what is to be normal, and what to do if somebody is, let's say, clinically normal, but socially he or she has abnormal status. Is this our task, our job, or not? And we are discussing a lot about medicalization. That's the thing that we frequently do. We are offering medicines. And so frequently in the group discussions with trainees, we discuss the problem like, does deviation from social normality need treatment? Yeah. So we think that also that sometimes or many times normal range is not optimal range. And these are just some sentences from our discussion from our module. The only normal people are the ones you don't know very well. We can find out if this is true. Yes, in Slovenia we have long tradition this within our profession. However, we are increasingly faced with the fact that we are trying to solve problems for which we are not responsible. And some of the support services required are substantially insufficient, especially in the period of recession. So GPs are frequently the last refugee of patients that the only thing that they can do is to listen to them and try to understand. And we discuss if, of course, if there is a limit, and about our goals as teachers. Shall we safely hide ourselves within the ivory towers, or shall we be activists, as we could hear yesterday, or advocates? The discussions are usually very good in the group of trainees. So I would recommend this also to other countries to introduce it to schemes, educational schemes. And as you could hear, I'm also the vice chair of European Forum for Primary Care, and Slovenian part and the forums part. We think that the final destination, final goal is that we are integrated in primary care. But let's go back to John's story. That's the real story, you know. In real life, you can see that sometimes only good people represent a solution for isolated, miserable people. The words from definitions and from declarations are not transmitted to actions. So on the one side, we have to thank our primary care teams to do this job, to adapt situations and to help people. But on the other hand, we should think that social community, or we as broader community, we are also responsible to help those people. And that's all for, for now. I'm sorry that you didn't see John's drawings. you would enjoy it in this. So I hope that I will accompany you next time, because I really enjoyed to be here. And thank you again that you listened to me. Thank you.
Thank you. I'll get you to stay. Well, I can't think of a better way to begin the day than with a patient story to really bring some of these concepts to life. That was excellent. We do have a little bit of time for a couple of questions, if there are any in the audience. In the back. We'll have a microphone circulating, I believe.
Hi, thanks very much for your interesting presentation. Can we find details of the evaluation, and preferably in English, anywhere online?
I'll ask Jenny if she has the answer to that. Or Karen?
I meant her evaluation.
Could you just, if you still have the mic, could you just repeat the question for us again?
I was just asking whether the evaluation that our colleague referred to about her work is available online anywhere.
Oh, her work. I'm sorry.
Yes.
I thought you were referring to our evaluation for the meeting. So, available online? Evaluation for your work?
No, here not. I mean, but as I said yesterday, you can write me and I will send the article is in English.
That would be fantastic.
Yeah. We have many articles about Roma in smoking, Roma and self-care, and this interventional educational, also health literacy study. So you are warmly welcome to write to you, because I have everything to prepare.
Fantastic. Thanks very much.
My apologies for misunderstanding your question. I'll try a second one if anybody wants to venture. All right, well, thanks very much for your presentation. Well, with that, I think we'll go back to the original order, and I'll turn the mic back over to Sir Michael to finish the next part of the morning, and then you'll see me a bit later.
Last evening, after dinner, I was walking north up the main street. The BMA House is on, and on the corner of Euston Road is St Pancras Church, and the portico covers a flat area. There was not a square centimetre of space that was not covered by a person sleeping rough. And the thoughts that went through my head, this was firstly, it's only 9:30. That's a bit early to go to bed. Isn't there something more interesting to do? Then you realize what an impoverished life means. It doesn't just mean lack of shelter. It means you haven't got a living room. You haven't got, you think if you get home at 9:30 in the evening, you think to yourself, well, will I read? Will I relax? Will I do this? Will I do that? Will I do the other thing? You've got 59 possibilities of things you'll do in the evening. Homeless, nothing else to do but get into your sleeping bag and huddle up against the cold. Impoverished lives in this great city. We have housing changing hands for tens of millions of pounds, vacant most of the year because they're owned by mega rich people from around the world who find London a convenient place to buy a pied-à-terre, which they don't use for more than a few weeks a year, and we've got people sleeping rough. Is that our responsibility? What our colleague from Slovenia just said is, yes, it is. And in a way, this conversation began, the conversation we're having here, with Jeff Turnbull and myself when he was president of the CMA, because he said, how can I treat the illness of people who are homeless without dealing with the fact of their homelessness? We said when we began the Commission on Social Determinants of Health in 2005, what good does it do to treat people's illness and send them back to the conditions that made them sick? And what you've just heard from Slovenia, one of my favorite countries, is that it's the primary care's physician responsibility to look at the wider issues. Thank you. Reflecting then, as I was asked to do, on what we heard yesterday, and then talk about what next, I picked up a few themes from, and I'm not going to mention every presentation by name, but I'll pick out a few examples. The first theme I wanted to pick out was the importance, on the one hand, of engaging the population, and on the other hand, of engaging government. Now, we are National Medical Association, so I'm not quite sure what we are. I think a civil society group, neither the people nor government, but a civil society organization, or set of civil society organizations. And what we heard, and the example which I thought was very impressive, of Canada going out and asking people. When we were conducting the English review, we had a conversation at one of our meetings about what we could do to get the public more engaged in these issues of social determinants of health. And I said the only rule for our discussion was that a sentence may not begin with the words "Michael should," but any other idea was to be entertained. Well, what you showed us, Chris, was going out and engaging the population was not only a way of getting buy-in, but it was a way of learning, being informed of what was appropriate in the Canadian context. Given how different our different contexts are, engaging the population has to be vital. But that's not enough. And what we heard from Finland was the importance of engaging the government, of actually setting the agenda from government. So engaging the people and engaging government are both vital. One without the other is not enough. A second theme that I picked up in different ways. Miguel from Brazil talked about the fact that the culture of the patients is so different from the culture of the doctors and the medical students. They come from different socioeconomic and cultural backgrounds. And we heard the same theme in talking about Indigenous Australians, that we have to understand the outlook. I think you used words like spirituality, the background. And that's an important part when we talk about social determinants of health. When we began this journey, people said, well, what about social and economic determinants? And somebody else said, well, what about social, economic, and political? What about social, economic, political, and cultural? What about social, economic, political, cultural, and environmental? And in the end, we said social will cover all those things. So the culture, the belief system of the people that we serve is absolutely vital. Whether it's these huge inequalities you see in countries like Brazil or other countries of Latin America, or just north of here, 2 blocks north, under the portico of St. Pancras Church when people are sleeping rough, or whether it's Indigenous Australians. The figures that I looked at recently, Australia, I think, ranks 3rd in the Human Development Index after Norway and Canada. And if Australian Aboriginals were a separate country, they would rank 110th in the Human Development Index. In one rich, privileged country, we've got these extremes. They're socioeconomic, but they're also cultural and political. The idea, picking up from Sweden, I think you said we are a country that can do better. We fall in the do better category. I've noted that not just on PISA scores, which you mentioned. PISA is the Program of International Student Assessment of children aged 15, but in measures of child well-being. Sweden has slipped behind Norway, the Netherlands, Switzerland. Used to rank at the top, and one rank below now. My colleagues say to me, "You're not going to Sweden again, are you? Why are you going to Sweden? Why don't you go to Ethiopia? Surely they need it more. To Zambia. Why Sweden?" Well, Sweden's decided we can do better. And that's why the activities you talked about in Malmö, in Linköping and Norrköping, in Gothenburg, now in Östersund, and now nationally, is a way of saying, yeah, we're doing very well, but we can do better. And in fact, if you look, the figures we published in our EC review, if you look at child poverty before and after taxes and transfers, Slovenia has lower child poverty levels after taxes and transfers than Sweden does. It's pretty low in Sweden. You look a good deal better than we do. 12% child poverty prevalence in Sweden after taxes and transfers, 19% in the UK, but it's 10% in Slovenia. It's saying we've engaged the government, one way or another, to say we're intolerant of child poverty. I won't embarrass my American friends by saying what it is in the United States, but it's a good deal worse even than the UK. Natural disasters. We heard from Myanmar about coping with a hurricane. I mentioned to some colleagues at dinner last night the earthquake in Haiti and the earthquake in Chile that happened not so distant in time. Compared, the one in Chile was 500 times the strength on the Richter scale than the one in Haiti. The devastation in Chile was minimal. Now, the epicenter of the quake was closer to the center of population in Haiti than it was in Valparaiso in Chile, but it was 1/500th of the strength in Haiti, and it was absolute devastation. Why? Because Chile has better social organization. They had building standards which were regulated so that buildings were more earthquake-proof. They had better emergency services. Within an hour of the quake, President Bachelet was out on the streets, visibly seen to be coordinating the emergency response. For 24 hours after the Haiti quake, no one knew if the president was alive or dead. What turns a natural phenomenon into a disaster is the level of social organization. And if we're doing some work now in the Eastern Mediterranean region of WHO, the Middle East, essentially, North Africa and the Middle East, 2/3 of the countries in that region either have or are recovering from armed conflict. That's like a natural disaster. And the level of social organization is both a determinant of armed conflict and affects the societal response. How on earth do you organize improving the conditions of people's lives when people are killing each other and burning their houses and totally disrupted? So it's a key social determinant of health, and it's a major challenge for those of us who are concerned with improving the quality of people's lives. I don't pretend to have a magic wand and know what the easy solution to that is, but it's very clear that it's damaging people's lives. So just like natural disasters, I suspect, can be improved by better social organization, so can armed conflict and their consequences the likelihood of armed conflict be diminished and the consequences of armed conflict be diminished by improving the quality of people's lives. The question was raised right at the beginning of the morning. We have one person here from sub-Saharan Africa, the region of the world that needs action on the social determinants of health, the conditions of people's lives the most, has got the least activity. I just talked about Sweden having regional Marmot reviews on health equity all over the place, and you could say they need at least, they want to do better. And what we're hearing from Zambia and from our absent friends is that the region of the world that most needs these kinds of activities is getting them the least. Now, I don't think of Africa as, oh God, it's all too difficult. Recent work coming out of UNDP suggests that, quite different from the bad press that Africa gets, it is growing economically, it's developing, democracy is improving in many African countries. Yes, there's still a lot of armed conflict about and a lot of terrible things happening, but a lot of good things happening too. One way of improving it is to take action on the conditions in which people are born, grow, live, work, and age, and the inequities in power, money, and resources that give rise to those conditions. The junior doctors and students who are here and who've heard me say this before, I'm sure won't mind hearing me say it again, but one of the reasons for my undying optimism is our students and junior doctors. They galvanize us, they inspire us, they show that they've got the big picture in mind. It's not we older folks who've got sight of the big picture, it's the younger people who are focused on what we have to do. And you saw climate change, trade arrangements, inequities on the agenda of the junior doctors. So as long as they're out there active, creating the conditions for our junior doctors and our medical students, we are in good shape. And so I want to thank our younger members. That's my little summary roundup of yesterday. What I want to move on to now is what next. And we put on the program a slot for me to talk about what I'd like to do during my presidency of the World Medical Association. It's no surprise, I've said it very clearly, that my priority is to get social determinants of health on the agenda. Anyone for whom that's a surprise really hasn't been listening. So that's my priority, to get it on the agenda. The question is how. And I had three thoughts, which we put in a little two-page paper, which was in your pack. The first was to continue to foster, establish, strengthen global networks. This is, in the end, a networking meeting. This is what we're trying to do here. And as soon as I stop talking, we move into a general discussion about how to strengthen, take forward the idea of global networks. And the kinds of things that I have in mind is that people can sign up. One of your Canadian colleagues was talking to me last night about, well, should we be doing something like establish an Institute of Health Equity in Canada? Why not? We would be very happy to have a sister or a brother, a cousin, in many parts of the world. mutual support, mutual learning, exchange. Why not? It would be one way it could work. And related to that, when people ask, well, okay, we're committed, how can we take this forward? Mutual learning, that's part of what a network should do. Learning from what's happening in countries that are doing things appropriately. And third, related to that, I don't for 1 minute want to overstate the impact of a declaration by the WMA. They get debated in great length. The full stops and the commas and the phrasing get debated at great length, and then everybody's very pleased. It gets passed by a committee and a council and an assembly, and then it gets put in a cupboard. So I don't want to overstate the importance of the WMA declaration, but one of the things I think some of us would like to do is to give those declarations teeth, make them go somewhere. And that relates to my second and third priorities. So the second one was what I had in mind was to produce a report, a WMA report. It could build on the one we did in Britain, our workforce report, on what doctors and other health professionals can do to tackle health equity and social determinants of health. In other words, to pick up the theme of this two-day meeting and turn it into a report. And that report should be built on not just our understanding of the science and the principles, but also good examples of where it's made practical. So everybody warm to your story of John. I can't imagine a Slovenian named John, but never mind. But everybody warm to your story of John. If you've got good examples, I mean, they'll throw me out of my research union to talk about case studies. I'm an epidemiologist, you know, you've got to have chi-squares and t-tests and control groups and et cetera, control for confounders. They'll throw me out of the union. But case studies are compelling. We've got, I think, a good understanding of the science. The case studies show us how to do it, how to put it into practice. So now here's my ridiculous ambition. The best thing the World Medical Association has done, and of which it is rightly proud, is the Declaration of Helsinki. Before I even knew that there was anything called the World Medical Association, I knew about the Declaration of Helsinki, which set the ethical guidelines for research. So a very important document that all of us in research knew about, even if we didn't know where it came from. It came from the WMA. And in fact, WMA has just renewed that, and there's a new revised Declaration of Helsinki. I'd like a WMA declaration on social determinants of health that said that doctors have a wider responsibility. We as doctors are concerned with the health of our populations. We have a wider responsibility to address the causes of the ill health of our populations, and this is how we propose to go about it. So it's not just a declaration, but it's a guide, a report on how to do it, built on the best evidence and the best examples. Now, complicated procedures of approval and so on, but ideally, WMA would say, this is our approach to improving health, inequities in health within our countries and between our countries in the world. We want to be a voice that's heard, and we want to give advice to our members. So that's building the evidence base and putting it into a form that could be useful. If we can do that, I would be absolutely delighted. And the third is education and training. Now, one thought that we had was to develop a MOOC. Don't ask me what a MOOC is. It's a mass online open course the idea, in fact, I've talked to people at my university who said, yeah, we've been a bit slow to get into MOOCs, but we'll think about it, and we would offer you some help. So we already have an offer of financial support from UCL, University College London, to develop a MOOC, mass online course. But also we could have workshops. For example, one thing leads to another. A few years ago, Joe Ivy Buford from the Institute of Medicine in the US asked me to come and talk to the International Academy of Medical Sciences platform. And I said, well, it's a long way to go. They were meeting in Kuala Lumpur. It's a long way to go. I'm only really interested if I think it would lead somewhere. And Joe said, hoping that lightning wouldn't strike, it will. Trust me, I guarantee. Well, she worked away at it, and we did a workshop in Trieste last summer. We had representation from, I think it was 22 academies of medical science, including several from Africa. And I said at the end of this workshop, there are 22 countries represented here. If 2 of you go home and do something about this agenda, I would say this has been a successful workshop. If 3, that would be a bonus. And any more, I would feel I'd died and gone to heaven. Not yet, they said, we need you. Well, since the workshop, I've been to South Africa, Colombia. We have invitations, I haven't been able to go yet, to Morocco. That's 3. And now we've heard that Tanzania would like to get active and do something. That would be 4. But that's good. What if we had some regional workshops on social determinants? So apart from a mass online course, that we got national medical associations, academies of medical science engaged, and conducted regional workshops where we try, sub-Saharan Africa would be a priority. And when I was in South Africa, they were talking about trying to create a capacity in South Africa for their southern African region. So what they did in South Africa would actually serve neighboring countries as well. So one could see wherever it would be, if Tanzania was getting active, they could be a hub. Francophone Africa could be another hub. So the idea, Latin America, we've got a lot of interest. I think there would be no difficulty getting that going in Latin America. We've had a lot of interest, Brazil, Chile, Colombia, Peru, Costa Rica, and I'm sure we'd get others engaged. So I think Latin America and Mexico is going to be relatively straightforward to get that going. It'll be tougher in Africa, but we've got good contacts in the Eastern Mediterranean and North Africa. I think it'd be well possible in that part of the world. So that idea of getting people engaged, having training workshops. Another thought I had was maybe, just put it out there, the rich medical associations, the medical associations from high-income countries would sponsor young doctors from low-income and middle-income countries to be trained in this arena. Seems to be another potential way forward. So, my 3 priorities in taking this forward. The first is to create global networks, and that's the discussion I want to go into now. The second is to enhance the evidence base and produce a report based on that evidence. And the third is to continue with education and training, and the 3 possibilities I've been considering were MOOCs, training workshops, and sponsoring young doctors from low-income countries, as well as from middle and high-income countries, to attend regional training. So what I'd like to do now is sit down and go into workshop mode, but in plenary, of how we create global networks. And it would be good if, thinking about what I saw as very lively discussions going on before we finished yesterday at each table, my guess is there's quite a lot more to communicate based on those discussions that will relate to the issue of how we create global networks. Thank you. Throw it open for discussion. What can we do to advance global networks? I think Chris is not here, Block. No, Dr. Block, who was talking to me last night. Well, never mind, because what I was thinking was just to get the conversation going, if I could ask our Canadian colleagues, given how in a way we've already been networking, how you might see that developing.
Well, as you suggested, Sir Michael, I think part of the equation is finding out a way to have a dialogue with our citizens. And I've wondered whether this is something that is better suited to the Canadian and US context, but town halls have been a great way in both the political sphere and in any sort of, any time we need to communicate directly. It seems to work very well to engage the press and to engage the consciousness or the sensibility of a country. And I'd be interested in what others think the utility of that might be in their particular cultural, political context, because we found it to be a very successful way to build the conversation.
So, interesting question. Is that a model that could be transported? Please.
Hi, I'm Sue Bailey, Chair of the Academy of Medical Royal Colleges in the UK. I'd support our Canadian colleagues' suggestion, because we've found this has worked very well in local government with local councillors getting mental health champions to champion mental health and the inequities that are embedded in having a mental health problem. So I think it's a way that you could engage with local government. Manchester are going to be, where I come from, is going to be an ideal opportunity because all the money has been taken from the health budget and given to social care. So it's a real opportunity, and if doctors don't get in there, we're going to lose out all round. So I would simply support the colleague's suggestion. Our mental health champions are run with a charity, the Centre for Mental Health, of which I'm a trustee, and I'd be very happy to liaise about how that could be done and take the idea further into Europe, at least for mental health. So thank you.
Thank you for that. And you touched on a vital issue, which for the non-Brits has been very much in the news here, the fact that if you don't address social care, particularly for elderly people, it puts more strain on the health service, and that you can't just deal with the health service in isolation from the circumstances particularly affecting elderly people, but it would apply more generally. So thank you for that. It's a very constructive suggestion about how to take the network further across Europe. Anna.
I think there might be a little confusion around the term town halls. I don't know if it's just a Canadian term, but what our town halls have been in Canada. Sorry, I'm Anna Reid from the CMA. They were actually outreaches where we actually invited members of the public, municipalities, and the media to actually explore various issues, and we did a big series on social determinants of health, but it actually wasn't going to a town hall municipal meeting, and so that's a whole different kind of outreach we need to do specifically. But this was for members of the public, open invitation to come to a meeting in a certain city where we invited everyone and just heard what they had to say. So just to clarify what we mean in Canada by a town hall meeting.
Thank you.
My name's Andrea Williamson. I'm here as the teaching lead from the Health Inequality Standing Group at the UK RCGP, and I'm also on the GPs at the Deep End Steering Group, and I'm from Glasgow, as you can probably hear. I think it's interesting that I think one of the things that we've grappled with, particularly in the GPs at the Deep End Group, and we've not got it right yet, is how to engage and help people be included in where things go forward in terms of people who are marginalised, so either people who are part of marginalised communities or people who probably wouldn't even self-identify as being part of a community. And one of the organisations that we've had some involvement with is an organisation called the Poverty Truth Commission, and it starts from the place that people who experience poverty are actually the real experts in all of this. And if they are not absolutely included in what happens, then there's no point. Their phrase, which I always get wrong, is nothing about us is for us without us. And actually, in small ways in Scotland, they've been very successful. They run this thing called a mentoring scheme where they go into different, either local authority and actually even Scottish Government, and they provide mentoring for people who are in key positions, so that they learn a bit about, how Scottish Government or local authority might work, but really importantly, those professionals who often come from very middle-class backgrounds get to learn about, well, how does my policy actually turn into practice, and what are the sort of things that we need to be thinking about? So I suppose what the point of me saying all that is, I think it would be absolutely wonderful if the World Medical Association could actively think about that when they're going forward into their global networks.
Thank you. I'm looking at the table in front of me and would like to ask colleagues from Trinidad, Zambia, how would a network help you? If you said, look, we really want to get active, you and I have talked on various occasions. What could you get out of a network? I mean, how would it help you get things moving in Trinidad, for example?
Thanks. Good morning to everyone. Sulaiman Juman from the Trinidad and Tobago Medical Association and also president of the Commonwealth Medical Association. Well, yesterday I had some discussions with my colleague from Trinidad here about how we can move forward. And we kind of set up a small timetable. The first thing that we needed to establish was the issue of convincing our colleagues that how important the social determinants is. Now, we're planning to have some preliminary meetings with our board, because if we are going to go forward, it's going to be the Trinidad and Tobago Medical Association driving it within Trinidad. And one way that the World Medical Association and this body can help is just by giving the support, or as we saw yesterday, there's a document from the World Medical Association, and plus maybe something coming from this meeting so that we can carry back to our medical association saying that, here what, this is very important, and this is where a lot of the national medical associations of the world are going to be involved with. So that external support, I think, is a very important thing to try to convince our colleagues. The second aspect that we're looking at is following the model, and that's why I asked about if we can get copies of some of the presentations so we can look at the good models. The issue of the town hall meetings, we are looking at having a few meetings in our country, and we already decided that, yes, we're going to have a social determinants working group, inviting all of the stakeholders at small meetings to start with, to sensitize them, to get them on board, and then expand to the public and the mass media. So certainly support from the bigger community and presenting this to our local folks, I think is very important to show that here what the rest of the world is following this, and this is very important, and we need to get on board. And from the Commonwealth Medical Association point of view, the parent body for the National Medical Associations of the Commonwealth, we spoke yesterday about this, in that I think this aspect is so important that we can look at this being the theme for at least the rest of my presidency. And we're having some discussions, as we mentioned yesterday, of you presenting at a bigger forum of the Commonwealth Medical Association. So we have some ideas in how we're taking this forward, but certainly the issue of the World Medical Association and all the other grouped bodies, the European Medical Group, the Commonwealth Medical Group, and all the other groups, I think those bigger bodies coming together would give us a lot of support in selling it in the first instance to our doctors and probably more importantly to the politicians.
And could I ask, is there, I'll ask it as neutrally as I can, is there a constructive way that the Pan American Health Organization could help in a network in your part of the world?
Well, as you know, that Trinidad and Tobago Medical Association, Trinidad and Tobago falls within the Pan American group, and as you know, Sir George Allen, who has been a big player in the Pan American Health Organization, is a supporter of this as well. Absolutely. I know our Minister of Health does attend those meetings in Washington, and I think that's it. It's small rivers flow into bigger streams and to the bigger ocean. So each group starts doing their work, and then the bigger group within which they function starts mobilizing, but it starts off with the individual group.
What about Zambia?
Good morning, everyone, again. So I think for Zambia, we have a lot to do. First and foremost, just looking at the way our association is, as the region, there's a lot of fragmentation. I think the first thing which we need to do is to see how we can bring all the players on board. For Zambia Medical Association, we have a committee on public health in the association. I think when we have to engage this committee to see how we can bring all the key players on board. As a country, we've got a lot of good publications, as I've said, but they are so fragmented. We need to get back and put everything together to see how we can start working on it. And I think going forward, we'll need to engage the leadership more to see how best we can bring everything together. Now, this one, I think we'll need a lot of help from the network, because yes, as much as we've got a lot of write-ups, a lot of goodwill, there's no that deliberate policy to try and put everything together to see how best we can drive the agenda of social determinants of health forward. So as the Zambia Medical Association, really ours is to try and engage all the players to see how best we can go about it. But suffice to say that we have to find out as the association what is happening from the regions. I don't know at the level of the African Union what is being done. I think we need to engage the minister more, because he attends a lot of these meetings, to find out really what are they discussing as far as the social determinants of health agenda is at the high-powered meetings which they usually go to. And there's a lot of work which is being done in Zambia, but as I said, we really need to put everything together. We need to engage the local leaderships, we need to engage the politicians, we need to really bring even all our colleagues on board to look at it from the perspective of social determinants of health. Because as doctors, what we've been doing mostly, we are not looking at the public health, the cause of disease from the public health context. What we are doing is seeing this patient, treat the patient, release them again to the same places where they are having problems. So I think we need to work. We need to work really very hard with the local authorities. There's a lot of fragmentations. I think that's where we need to put everything together.
Well, because we could say that if we have not found a way for a network to work in sub-Saharan Africa, countries such as Zambia, then we've not succeeded. The network's failed in one key goal, which is to bring these ideas and ways of helping to a broader array of countries. So I think it's potentially an important challenge. Andre.
Andre Bernard, the Canadian Medical Association. It struck me in the last day, and I think we'll see more of this afternoon, that we're sharing a lot of specific ideas that are context specific. So, I take away, especially hearing our colleague from Slovenia speaking about what has worked in that country. So it strikes me that perhaps what we need to think about is what is the function of a network. And to me, that the function of a network is to build capacity at the level of a physician, an individual doctor, and at the level of the National Medical Association for taking action. So what are the specific functions we're speaking about? To me, it's about building capacity for NMAs to do advocacy, because not every country has the same mechanism for physicians providing input into, say, poverty reduction strategies. It's about media and communications. It's about civic engagement, some of what Anna and Chris spoke about earlier. So what are the pieces that allow us to work effectively on the social determinants of health as NMAs and as individual doctors, and then find ways of pairing up those contexts that have demonstrated excellence in a function and partnering that with other NMAs or other physician organizations to build that. So it's really finding what are the tasks or the points of entry, finding best practice and translating that through the network. So I would say that we, not just establishing the network for its sake, but actually looking at the functions and identifying where best practices are might be a start as well.
Thank you. There was another, yes, please. Oh. Okay, there, and then at the back.
My name is Clarissa Faber. I'm from the Medical Women's International Association. Last night I went to a very interesting meeting at Westminster, which was arranged by a shadow minister with responsibility for women, and she was looking particularly at violence against women and girls particularly. But it was a getting together of all sorts of people, and she organised it. There were people from all walks of life, people who were all interested in this. There were victims of violence, there were people interested in FGM, and people from the local government. So my main point is, I think we have to identify politicians who are interested in the actual thing, where, like I'm interested in violence against women and girls. Identify a politician. And in the UK, in the last year, they've had several very interesting meetings. You know, there was a global summit on sexual abuse in conflict zones, and William Hague, the Foreign Secretary at the time, and Angelina Jolie arranged this, a big meeting. It was very successful. I'm not sure how. So it's on the agenda now. There's another meeting, the Girl Child, which is looking at forced marriage, and FGM. Again, that was very successful. And then victims of FGM have come forward. So, and momentum is building. So I think it's important to identify a politician who's interested. I mean, I was the only doctor last night. Get people from local council, invite people who are interested in the subject, and get them talking. And there were people from the community. There were men and boys who were involved in trying to tackle violence against women. And they're Muslim people, actually. And they were mobilising people in their own communities, but only on a very small scale. But it has to be done on a widespread basis and all coordinated. But I think doctors have a very important role as well.
Thank you. And it occurs to me that I'm just thinking about, Chris, your list that emerged from the town hall meetings. One of the issues that we have difficulty with is social determinants of health. When you're talking to ordinary people, sounds a bit abstract, airy-fairy, whatever. Poverty, exclusion, disaffection, violence against women sound really concrete, and that's what we're talking about. So it's translating the general concept into the reality of people's lives. That's what you were saying to us. Thank you. Good. There, and then at the back, and then Aubrey. There next, Jim.
Yes, hi. I'm Corey Newdorf. I'm a public health physician in Canada and a researcher in health inequalities. What I found locally, reporting on the issue and convincing physicians that this is important has not taken a lot of work. As I go around to different specialists and show them the data, they're convinced, but what I find is they get paralyzed about what to do about it. And I'm finding that a number of people will go on to become advocates, and they do want to work to change the system. But the bulk of physicians aren't going to do that very easily, and what they're looking for is, how can I use this information to change the life of the patient sitting in front of me today? And the first thing I try to tell them is, do you know what their social determinants of health are? Like, have you asked them? Because it's not always obvious. So are you systematically collecting information on your patients that allow you to stratify them according to those needs? But then they're looking for tools of, once I know that, how does it affect my care plan or my discharge plan for that patient? How can I improve health outcomes in a group? And I think we've heard some good advice today around listening to your patients about what the barriers are to even following the advice the physician is giving you based on your social circumstances. But one of the things then that NMAs could be doing is collecting that evidence. We've seen some good innovation from family doctors, from specialists, to make those adaptations and to publicize them so that physicians actually know the advice I'm giving isn't practical for someone in this circumstance. How can I actually adapt that advice and connect them up with the right types of agencies and support to turn their social determinants around? So I think it has to affect both the causes of the causes, and it has to affect the advice that they're giving their patients on a daily basis. That concrete sort of assistance would really help.
Good. Yes, please. At the back. Well, we'll go there. At the back.
Yes, I'm Kathy Felderhoff from Canada. I've worked with First Nations peoples for the past 20 years, and one of the statements they presented to me is First Nations peoples and second-class treatment. I like your concept of engaging with the population and then engaging with the government. In Canada, we have a program called the MD-MP program, and it works very well, and it might be an avenue that we can mobilize even better. But I take the opportunity I am a match for our MP in our area, and he happens to be the Justice Minister of Canada. So it may be a mechanism that other countries could use, is to make sure that you can implement that type of a program, an MD-MP program. And it's a wonderful avenue, and you get the ear of government, and it's within your own country, but it's a very useful program. Thank you.
Thank you. Aubrey.
Aubrey Shine from University College. I just want to merge what you said, Michael, about engaging the community, engaging the professions. And one of the things that one needs, and our colleague from Zambia brought this out, and also the question came up about capacity building, is that on the one hand, we have to develop indicators of social determinants which could be used by doctors, and that's you saying we should expand the evidence base for what is required, so we have a sort of a template. And the second thing is how then to engage with the community. And one of the examples we have here just north of where we're sitting in Islington was the local council had a commission on social inequalities and social determinants. And that was chaired by an expert. Richard Wilkinson was brought in. And through that mechanism, the council and the experts developed a plan for our community. So those are the two sides of the story that, I mean, it's all very well having a town hall meeting. I'm not saying that's not good, but it's an ongoing relationship which then gets built into policy by the local politicians and the physicians and doctors and physiotherapists. Everybody gets involved in, but we have indicators to say what are social determinants, and secondly, we have ways of monitoring whether the system or what the plan, whether the plan is working. So I do think there's a very important role, and you're mentioning about workshops and capacity building are vital, because the worst thing we can have is people, well, let's say from the medical side going in without having a clear view of what social determinants should be looked at and how they can be intersectoral. The other thing is, we haven't talked a lot about, one speaker mentioned yesterday about using general determinants, not being disease specific. So we have sort of a common risk factor or shared risk factors that we should be looking at, and where they are in the community, where the deprivations are. And just give you a very simple example. I'm a dentist, and we have data on the decay rates in different schools in Islington. And from those data, we can say this is a school in the deprived, and you can link that to the local area, deprived area, the number of decayed teeth in these children much higher, and we know which is the schools which have low decay rates, and we can look at that area, and you can plot that out in terms of other measures of deprivation and so on. Thank you.
Thank you. 1, 2, 3. So.
Thank you. Gary Robgent. Thinking about the Manchester example that Sue Bailey raised, because within a UK context, I think it has huge potential. I'd ask the WMA to be a little more ambitious. The WMA is a prestigious organisation, and assuming that the national medical associations are on board with addressing social determinants of health, if you look at some of the policies of the WMA, WHO, and indeed the World Bank, and then you look at Manchester, the Manchester initiative has come about not because of health problems, but actually because of a desire to create a northern powerhouse. It's because of looking at the local economy. And that came about because of work that was looking at to produce the high-speed rail link. And I think there is something about the WMA and the National Medical Associations reaching out and using the prestige, using their contacts, and looking at actually the economics. So bringing in to look at social determinants of health, people that and organisations that haven't hitherto thought about it. So looking at industry, looking at the wider government, and I think only then will the discussion really take off, and will we start actually not just medical associations joining things up, but actually the wider organisations, whether government bodies or civil societies. Only then, I think, will it go forward.
Thank you. And please.
I'm Angela Moore, previously the UK BMA House Association, and now from Southampton University, helping public health in the medical school. I'd like to, talking about global networks, Sir Michael, I think yesterday you mentioned that several countries, well, many countries, are on the path and some are further ahead than others. And I'd like to say, why can't a national network who's further along the path do more about it, namely, I suppose, in the UK? Given that we had the Black Report way back in the 80s, we had the Aitchison Report in the 1990s, your eminent reviews in 2000, whatever, I've forgotten. But we don't seem to be engaging with what that actually means and the political interaction which I believe would have to take place. And I haven't heard any mention of the election, which is coming up in 5 weeks' time. And I think that everybody skirts around the issue of politics, but you yourself said how you came across the people lying in, you know, it is a disgrace. And I believe, as a gentleman said over there, that if doctors were champions and if they were able to, because the public trusts the medics so much, rightly so, and if they were able to genuinely challenge how government interprets policy and how that impacts on the population, which after all is population health. And Sir Donald Aitchison, who I had a great regard for, he said that population health is achieved by the art and science of promoting health, preventing disease and prolonging life by the organised actions of society. And I believe that we have to engage at every level. And if that does mean politics, then it means politics and we can't run away from it. And that sometime in the future, when other countries are further ahead, it will help them to know how to engage with their politicians and genuinely represent the people in terms of their health.
Thank you. At the back.
First of all, I would like to thank you for allowing me to come into this conference. I'm a gate crasher. I'm a family doctor from the United States. I'm talking at the Royal College of General Practice this evening about health movements. I just happened to hear about this, and I wanted to come to the conference, so I just showed up. Okay. So I thank you. I managed to get through security, and you know, I was amazing. So this is really accommodating. I want to pick up on a point the Canadian colleague spoke about the function of the network, because I think that's such a critical variable. And that is, what is the function? And one thing that I would like to propose a simple idea, and I think there's lots of ideas already around this, but how can we galvanize around it? And what I'm calling health movements. Health movements are a combination of three things from my framework, which might be useful, it might resonate, may not. But it's a combination of leadership movements, it's a combination of professional movements, and it's a combination of social movements synergizing together and galvanizing around what I would like to call catalytic innovations. And catalytic innovations are scalable, self-sustaining, and self-organizing solutions that mobilizes the assets of communities to be able to take on these wicked problems. Because for those of you familiar with complexity science will know the term wicked problems. They're wicked, we're never going to solve them, but we can really have a major impact if we can align around them. And if there is a function, it is to focus on health movements. And I'll give you one example from the States that's just been initiated by the Institute of Health Improvement, which is to improve 100 million lives. And it's going to be a coalition of organizations coming together. And I'm just involved in a peripheral capacity, but I just wanted to plant that seed of an idea that the notion of how to develop capacities around health movements, how can networks do that? So what I may say may resonate, may not. I'm coming from outside in, and hopefully it might make sense.
Thank you. Apart from the good ideas you just expressed, you've given me a wonderful idea for a short story that somebody arrives in a foreign city and the difference between the British Medical Association, the Royal College, is a bit confusing, and he turns up in the wrong meeting. And there's a question of how long it is before he figures out he's in the wrong meeting. And none of it's making much sense anyway, so it could be any meeting.
Thank you. Mark and I were just discussing the representation in the room, and I think what is notable is that there's an absence of the Oceania and Asian region. So I was very pleased that Dr. Tun was able to be here and present yesterday. But to the north of Australia, there's Indonesia with 250 million people. We've got China with 1.4 billion people or thereabouts. So I think if we want a global network around these issues, particularly with these developing nations, we do need to try and reach out and make sure that the network is truly global. And I know there are a lot of barriers to doing that. The second thing is really about what you see as the role of the National Medical Association. I know that's a question that we talked about yesterday, and to me there's two main issues. One is advocacy and one is education. So a lot of what we've been talking about, explaining to our own membership what the importance of the social determinants are and how they can use that in their practice is one issue. But to me, as a National Medical Association, I see one of our key roles as advocacy. And I think there's a lot of work that a global network can do in terms of building the capacity to advocate, because many national medical associations are actually very good at advocacy, about building that passionate narrative for change, engaging not just government but also the media. Unless you're able to do that, you're never going to change the opinion of government. And I think this is really important in a time of austerity, but also where there are economies that are recovering and there is the opportunity to actually seek some of those investments. So just some thoughts.
Thank you. And that touches on, I'll come back what it touches on.
My name is Patrick Hutt. I'm a GP in Hackney in East London. I'm also chair of the Royal College of GPs Health Inequalities Standing Group. I'm very intrigued by about the meeting this evening, and I wondered might try and crash the Royal College later, but we'll see. I think I'm very inspired by the comments I've heard in the presentations over the last sort of 24 hours, and I think my view of a network is that it should capture and inspire others around the world. And I think it'd be a crying shame if some of this enthusiasm doesn't translate to doctors who are working, for a better word, at the coalface or the deep end. In East London we have GPs who are working sort of 13-hour days. Surgeries are under threat of closure, and I think there are many GPs who'd want to engage with these issues, but just the sheer challenges that are faced in the consultation room and the sort of local health economy, and I know this is not just in London, but this happens around the world. And I think I like the idea of trying to provide evidence and examples that people can go to, like the Institute of Health Equity, where we just see quite sort of easy accessible papers, examples where we can just say, go and have a look at this, go and be inspired by this. And I think it'd be fantastic if the presentations, slides could be up and accessible in a very sort of in the near future, and not to underestimate the power of things like Facebook. I know the Royal College of GPs Junior Doctors group, they have for the International Committee of Facebook that helps link junior doctors in primary care around the world. So I just wanted to share those comments. Thank you.
Thank you. Yes, please. Yep.
Thanks, Andrea Williamson again from Glasgow. And I want to follow on actually from what Patrick was saying there about life at the coalface. I've been really pleased that over yesterday and today the focus has been on primary care, and I think that's possibly a recognition that primary care-led health services are where we should be at in terms of delivering effective health care. But I do want to make a plea for coalface doctors, and I think this probably is a universal issue. I would expect that almost in any healthcare system in the world, the clinicians that are working with the most disadvantaged patient groups are also working the hardest in terms of numbers of patients, in terms of levels of complexity. And the emerging evidence about multimorbidity tells us that as well. So my plea is political. My plea to the World Medical Association and to trickle this into the network is that you look at proportionate universalism in terms of resourcing clinical care. That's a tricky one, I know, because that's one we've been trying to push as GPs at the deep end with the British Medical Association, and it inevitably means that resources need to be moved from richer communities into poorer communities, and that makes people very uncomfortable. but it would be absolutely delightful if the network of social determinants of health and the World Medical Association could take that on, please.
Thank you. And last comment, and then I'll have a few things to say. And then one more.
Thank you. My name is Blaus, and I'm representing the Czech Medical Association. My field is endocrinology, and I have slightly different point of view on social determinant of health. It has been shown in animal studies that stress and other endocrine disturbances may influence the social behavior of animals. And we are living in a stressful situation, in a social stress everywhere, every day. And certainly it may have a certain impact, a very important impact on social behavior and subsequently also on health. Unfortunately, I can't give any advice how to eliminate stress or at least mitigate the stress. Thank you.
Thank you. Mark Peterson from New Zealand. And I was just going to perhaps give an example of what a global network might look like, or at least what we did in New Zealand, because actually we created, or the New Zealand Medical Association put together a health equity statement in 2011. And the small network, as it was at the time, was Michael, who came to New Zealand and did a number of presentations to various groups, which included doctors, but also the New Zealand Medical Association were able to get Michael in front of the parliamentarians. They hosted a breakfast at Parliament, at which Michael spoke. So while we have this global network at the moment, we really have Michael. We need to expand that and have a few more Michaels, which is, I think, what you're talking about in terms of this global network.
Well, yeah, I'm offering myself up to be cloned. I mean, obviously success in one egocentric, egomaniacal way would be not to be needed anymore. That would be real success, and that it's self-sustaining and the movement takes off. And I think, you know, in Canada, that's certainly the case. It's self-sustaining, it's taken off. I mean, I had a role in it, I know, but I'm delighted that it's Canadian. And that relates to an issue of, on the one hand, if it's not invented here, we don't want it, syndrome. It's got to be invented here. On the other, and it happened to me in Canada, I addressed once in Ottawa a cross-departmental group of senior civil servants, deputy ministers, I think they're called, in Canada. And at the end of it, the chair of the group said, well, our chief public health officer could have told us all this, but we listen more because it's somebody from outside. So one way is getting somebody from outside in that can help. In other jurisdictions, that doesn't help. We don't want an outsider telling us what to do. We need to invent it for ourselves. So getting that right with a global network is obviously very important. I think a few of the points that have come up, which I think give us a good basis for building. The issue of let's get crystal clear what we want the network to do. Of course, that's absolutely vital. So let's get crystal clear what we want it to do. A second issue is, I said at the beginning of yesterday morning, this meeting began as a conversation between Canada and ourselves, and others said, we'd like to come. So this was people who were interested. Reaching out is vital. I did a thing on the BBC a year or so ago, and the BBC producer said, you're a professional optimist, aren't you? And I said, well, of course. Look, there's 193, there are now 194 member states of the WHO. Suppose it were the case that only 8 had got interested in this issue. I wouldn't go on the BBC and say that there's 176 countries that are ignoring us. I'd go and say there are 8. Next week there might be 12. And 3 months later we could have 20. In fact, there are many more than 8. We've got 20 national medical associations or other 20 countries represented at this meeting. I've reeled off half a dozen in the Americas. There are many in Europe and so on. So we've got many more. But we start with the willing, but then it's very important to reach out. And your point about Indonesia, China, Africa, the countries that are not represented here, I think it is important. And showing what's possible, I think, is vitally important. I mean, you raised the question, is anybody listening? We've had the Black Atchison, my own review. Yeah, tomorrow, with 1 or 2 of my colleagues, we're going to the English city of Coventry, which has declared itself a marmot city. Now, my mind boggles a little bit. I imagine rodents running around the city of Coventry, marmots everywhere. But we're going because they're celebrating 2 years of having been doing that, taking initiatives. So it's happening at the city level. And I think that's quite helpful because we can say to other cities, this is quite practical. It's quite doable. It's not just the doctors have taken it up, but it's local government. And the initiative has come from local government, not from the medical people. But I don't mind where the initiative comes from. It can come from, here we're discussing medical associations, but it can come from local government. So I think reaching out is vital, but the networking, and I think, Sue, that was your point about networking to the other. This is not a good way to arrange an assignation, but Sue, it would, as I'd like to take up your invitation to meet. It would be, if we could meet, arrange a time to discuss this further. I don't normally do these things publicly, but while we're in the same room together. But reaching out to other vital sectors is part of the network. So I think that if we feel that we here, the 20 countries represented, feel that this is a vitally important role for national medical associations and for doctors. And I think, as you said it's at different levels. One level is what can the practicing doctor do tomorrow, today? And the other is the advocacy role of national medical associations. Both vitally important, but if we feel this is important, then we need to find the mechanism to reach out to other countries where it's not happening, but it's highly likely that doctors and national medical associations in those countries would welcome guidance, support as to how to take it further. So I think that's been a very helpful discussion, and I'm very grateful. I think we've made up 10 minutes because we had 20 minutes of the Slovenia presentation out. So if we have our tea coffee break and come back promptly at 10 past 11, 11:10, then we're in good shape. Thank you very much.
I'm Chris Simpson from the Canadian Medical Association, and I'll be moderating session 3 on what physicians and other healthcare professionals can do. We'll be hearing from a number of presenters throughout the course of the day, and they'll be exploring what actions health professionals can take to tackle inequities as employers, as managers, as commissioners, as well as through frontline clinical practice. And we'll want to hear from all of you as well. We'll be dividing into breakout groups this afternoon to do some brainstorming on the theme as well. And I think we got a pretty good start this morning. A few of the questions we'll be asked to consider throughout the day are: what role do health professionals and healthcare organizations play in addressing the social determinants and health equity? And how can national medical associations support these initiatives? So we're going to get started with a couple of speakers who will be speaking to the sustainability and health equity agenda from the UK perspective and a wider policy context. And our first speaker is Dr. Gina Radford, who is Deputy Chief Medical Officer here in the UK. She first joined the department in 1998 as head of the Public Health Development Unit and has held a number of roles in public health across England. And I'll invite Gina to come and get things kicked off. And just in the way of organization, I think what we'll do is we'll hear from 4 speakers, then we'll have a common question and answer session, and then move to the next. So if you can hold your questions for each speaker, maybe write them down, and we'll have a common question and answer session after the first 4 speakers. Gina.
Thank you, Chris. Thank you, and it's a real pleasure to be here. And no, that's not from a picture of me in my childhood running down the street, I assure you. David, my colleague, and I are hopefully going to do a seamless double act, trying to set some of the policy context and what we're actually doing here in England and the UK around health equity and sustainability. And what we want to try and explain, as well as providing some of the context and background for what we're doing, is also to share with you how we're approaching what we see as 2 very complementary themes, that of health equity and sustainability, and how we're linking the 2. So this is very much a scene-setting presentation of what's happening. Health inequalities in England. We have a history in terms of addressing these issues. This is not something that suddenly we are coming to, but we have been looking at this for a number of years, as I know others have from other parts of the world. But this really gives you a little bit about our recent history in this field, starting back with the Atchison report in 1998, which was particularly seminal in really challenging the policy in terms of health inequalities and what we were doing. And a number of particular activities and policies that have resulted in the ensuing years. For example, in 2001, we had a very specific target around reducing inequalities and health outcomes. And in 2003, we had a national strategy, a programme of action to help achieving this. And then finally, in 2008, we had the Marmot Review, that very, very seminal review that was commissioned by the department and published in 2010. And it was this review that really emphasised the impact of social determinants on health and identified this social gradient, highlighting the importance of developing healthy and sustainable places and communities. Moving more recently, the government accepted the findings of the Marmot Review, particularly the key principles, and addressed these within a public health white paper that was published in 2010, which was called Healthy Lives and Healthy People. And also there was a very significant shift in terms of looking just at process and targets to looking at outcomes and what we were trying to achieve and can we measure that. And we've developed some public health outcomes in a framework for England. And 2 of those indicators are specifically related to health inequalities. Those are healthy life expectancy at birth and reducing the differences in life expectancy and healthy life expectancy between communities. So really significant changes in our thinking about inequalities and how we measure it. And then in 2012, we had the Health and Social Care Act, and that's had a significant influence in terms of how we deliver public health and also our national health services. Public health, for example, has now moved from the NHS to be embedded within local authorities. And CCGs, which are clinical commissioning groups who commission local NHS services, are actually now expected to set quantifiable ambitions around health inequalities with local partners, embedding health inequalities not just in public health, but in NHS and NHS commissioning. In addition, ring-fence grants in the order of £5.46 billion was handed over to local authorities, ring-fenced to be spent on public health services over 2 years, with a condition to consider health inequalities as part of the use of that ring-fence grant. In addition, health and well-being boards were created, bringing together local partners, and part of their role is to address health inequalities in the local communities they serve. And then finally, Public Health England, the national expert body around public health, was created with a particular remit to look at addressing the wider determinants of health with partners. Building on that was a real sense that we need to translate the good ideas that we've identified around research and enshrine these in some of the very legislative framework that we have for health and the health service in the country, and around some of the governance around how we run health and social care. So health inequality duties were specifically contained as legal duties within this Social Care Act, and 3 specifically that I want to highlight. Firstly, the Secretary of State, him or herself, must actually have regard to the need to reduce inequalities. So that legal requirement right at the top of the department. And then the NHS Commissioning Board that oversees NHS England and the NHS also has to have that regard to reducing health inequalities as set out. And then finally, at a very local level, when we're talking about local health commissioning, again, this importance of reducing inequalities being there at the heart of what commissioning activity is happening. And then finally, Monitor, which is the regulator that regulates health services in England, also has that duty to oversee in terms of governance that the integration of health services and health-related services and social care are actually focusing on reducing inequalities. So translating the good ideas from research, getting that legislative framework, getting some governance around it as well. And a really practical example, in Salford, the local clinical commissioning group, for example, has actually got health inequalities enshrined within its very local commissioning plans as an expectation and a way that they are wanting to move forward. And as part of all of this, clearly we see the role of health professionals being key in helping to address health inequalities. And in fact, the NHS Constitution actually calls on all NHS staff to endeavour to reduce health inequalities wherever possible in their work. So right within our NHS Constitution is this expectation, because we fundamentally believe they have an important role in helping to deliver the agenda. And to support some of this, Department of Health have worked both with the Royal Colleges, health organisations and the Institute of Health Equity to help develop this agenda across and with the professions. And this has included building on the findings of that Marmot review that I mentioned earlier, and working with the Royal College of Physicians on this report of how doctors can close the gap, which was published in 2010. And so the Department of Health have actually commissioned the Institute of Health Equity to work with the 19 Royal Colleges that we have in this country and other health organisations to produce an action plan that was published in 2013, which has delivered a number of recommendations and are particularly focused around 6 core areas. And you can see these core areas that are identified on the slide, covering everything from workforce to how we work with individuals and communities, how we work in partnership, the importance of the workforce as advocates around health inequalities, and also looking at how we can address the challenges and opportunities that we have. But this isn't just about the Department of Health working in isolation. There is genuinely a cross-government endeavour to promote equity and sustainability in terms of health inequalities. And these are some of the examples of things that are happening across government. I'm not going to go into all of them, but I leave these with you as an idea of some of the significant cross-government work that's already underway. And then finally, there is the wider engagement in health, in inequality and sustainability. And some of this I've mentioned in terms of the programme for action that clearly is a cross-Whitehall endeavour. One of the Health Select Committees highlighted the importance of health equity being in all government policies. And then clearly these lessons have been carried forward in the EU Joint Action Programme, and we have the forthcoming WHO Europe Country Report on health inequalities in England. And finally, I leave you with the fact that we are really trying to embed the whole question of inequalities and sustainability right through government, and all policies need to be reviewed in terms of how they achieve not just reduction in inequalities, but also how they achieve a more sustainable future for our population and our communities. So we see very close linkage between reducing health inequalities and helping to develop more sustainable communities and populations. So I'm now going to hand on to David, who's going to then talk about this from the sustainability angle and really show how we're linking these two agendas together.
Thanks very much, Gina. I'll give David just a very brief introduction. Can you hear me okay? Is my mic on?
Come on here, Chris.
All right. David he leads the National Health Service Sustainable Development Unit, which provides leadership, support, and policy input to ensure the NHS in England is the leading public sector organization in promoting sustainable development and mitigating climate change. So we've heard about health equity, now for the sustainability part of the equation.
Okay, thank you very much, Chris. So I'll be very brief. I just want to give you a little bit of background about what we've been trying to do, Gina and I and others in this country, around the twin challenges of equity and sustainability. The first thing to note, which I think is really important, is to have a very clear conception of what quality means. And in a second, when we've got the slides sorted, I want you to think, when you're asked, what do you mean by quality healthcare? What framework you use? Everybody uses a framework. They're all very similar around the world. But it is really, really important to have a framework. And one of the ones I'm going to show you in a second is the one from the Royal College of Physicians in this country. So thank you very much indeed. And if you look, you'll recognize this sort of thing about quality. You'll all have one, and if you don't have one, I recommend you do have one. It just means being clear. But what we've been talking about is in this is about equity and sustainability. Now, the really important thing about dimensions of quality is that these are not competing dimensions of quality. These are very synergistic. And I think one of the really important things about social determinants, social justice, sustainability, is that it has a very, very synergistic and positive place in our conception of high quality health and care. And the reason I talk about sustainability is because we as physicians, we as surgeons, we as health professionals are highly focused on the present. We are creatures of today. In many ways, we're crisis junkies, which make us one of the poorest people in terms of doing the future. We're very, very obsessed with today. I mean, the idea of planning in my clinical career was to reach the end of the clinic. Strategic planning was next week. So the issue of how our responsibility to future generations is incredibly important. And what this is modified from the Brundtland Commission, is about our responsibilities as health professionals, health systems, to our patients and public of today without compromising the needs, the assets, the opportunities, the reality of lives of people who have no choice and no voice. Those are people elsewhere in the world now and people as yet unborn. So I'll just say 2 or 3 things about climate change, but not very much, because I don't think this is really about climate change. And anyway, climate change is a scary issue. People don't like it. We're great at, Aidan Halligan will maybe tell you this afternoon, that one of human beings' most powerful coping mechanisms is denialism. We don't like this stuff. But unfortunately, everywhere you cut the data, this is going to be one of the big issues of our time. This will be what our generation is remembered for as professionals and citizens. It won't be remembered for the credit crunch. It will be remembered for the climate crunch and the effect it is having on the social determinants of our health. So these 3 journals here, some of you might have heard of them. So this is a big issue. We're good at talking about this. One of the things we've done in this country is to actually measure it. So I think we're still the only health system in the world that's measured our environmental impact. And I won't go into all the details except to tell you that it is about 1/3 of all public sector carbon emissions. 1/3. That is very large for something that does great things. The health system does great things, but there is a cost financially, socially, and environmentally. Now, when you look at this little picture very carefully, this is a picture done from the Lancet Commission in 2009, globally, of which countries produce carbon emissions around the world. It's a cartograph which represents the relative proportion. And you can see that the wealthiest so-called industrialized countries produce the most. Now, I'm going to show a next slide. We'll look very carefully, and see if you can see the difference between the countries and communities that produce emissions and the countries that suffer the ill health and consequences of it. Look very carefully and see if you can see. There you go. Can you see that? I'll try it again just in case anybody missed it. There you go. That's who produces it, and that's who bears the burden. These are WHO mortality figures attributable to unsustainable development. That is socially unjust. It doesn't matter which way you cut the data. That is something about which we as health professionals in any country and community in the world should not be particularly proud of. Now, I'll just finish by telling you a couple of stories about social sustainability, about social determinants. These are just stories. It's not the whole picture. This is a hospital in this country. It's Nottingham, actually. It's Queen's Medical Centre in Nottingham. Now, what they do in Queen's Medical Centre in Nottingham is they have some distinguished visitors there. That's the Prince of Wales they're visiting, because the Prince of Wales is very interested in this. And one of the things that's interesting about leadership in this particular hospital is this man who's assistant catering manager. Now, what this colleague of mine has done is he's changed the whole food system for the whole community of Nottingham. This hospital, I mean, food in hospitals is very, very politically important. People come out of hospital and they say, well, they cut the wrong leg off, but hell, the food was great. So don't underestimate the power of the total patient experience in a hospital. This man has invested £2 million into the local sustainable food economy. Is the best hospital food in this country, probably in the world. 15% of it is organic. £2 million into the local economy, completely cost neutral, but most importantly than that, he has employed dozens of people in this hospital preparing food who've been very difficult to get into employment elsewhere because they have learning difficulties. He's got them qualifications. He has absolutely shown how a health system can be a significant contributor, a considerable adder of social value to the community in which this hospital is situated. This is not a big health factory, an illness factory on the bypass of this city. This is integral to the community, so much so that citizens shopping nearby sometimes come and eat in the cafe there because the food is so good. That is impressive. Now, this is take you to the other side of the world. This is northern Pakistan. Now, many of you will know that most surgical instruments in the world start their life in Pakistan. Did you know that? Under appalling conditions. Appalling conditions. And you and I use these instruments every day. Do we ask questions about where they come from? I don't know, but maybe we should. Maybe we have a responsibility. Maybe we have an opportunity to do this. But the Royal College of General Practitioners and the BMA and the Medical Fair and Ethical Trade Group have come together in this building to try and draw a line in the sand and say these are the things that we as health professionals should not be knowingly party to. This is just one example of what we could be doing around the world. So in this country, what we've tried to do is to set out a strategy between the Department of Health, NHS England, Public Health England, to look at what it means to have a system of health professionals which can truly lay claim to saying we have a vision of a sustainable, resilient, healthy system for places and people, which means things like enabling social assets, enabling independence, enabling natural environment, and reducing inequalities and the burden of preventable diseases and the burden of environmental impacts, many of which actually come from the healthcare system. And that's it. And I'm around most of the day, and I'm very happy to talk to people about it. So just in summary, 200 years of health professionals. Now, if you think what we've done as health professionals over 200 years, it's mighty impressive. But if you look at some of these things, they're nearly all social determinants. Okay, HIV/AIDS, this is a virus, but actually these are social determinants of the people who die from this disease, all the way through. But this is happening on our watch now. It will be our legacy. This is not a future issue. So if you return to fair society and healthy lives, let me just, with this last slide, quote you some of the things that has been said in this report. Creating fair societies and healthy lives means tackling health inequalities, much of which is around tackling unsustainable development locally and globally. We have to break this cycle. If you've read Naomi Klein's book about, any of Naomi Klein's work about what situation we find ourselves in with very powerful corporate organizations, it makes the challenge that we had against tobacco look rather small when we look at the challenge we've got against very big multinationals, not just in the fossil fuel world. Economic growth is not the only measure of a community's success. So 5 very important policies to prioritize, which are all laid out in detail in the Marmot's report, around sustainable communities, transport, food, green spaces, and zero carbon housing. And the last 2 words are underlined because this is not about a dispossessed minority. This is about everything. Just go right back to the beginning about that gradient in Marmot. This is not about a small number of people over there. This is about everybody. It affects everybody in this room. It affects everybody out there. And we, as health professionals, are much more powerful, and we have much bigger opportunity than we might imagine. We're probably too powerful. We're probably too respected. But unless we use that mandate for the betterment of the people we purport to serve, we'll have missed one of the biggest opportunities at this end of the 21st century. Thank you.
Well, I'm already bursting with questions, and I'm sure you are too, but hold them off. We have a couple of more speakers, and then we'll open it up. Our next speaker is Dr. Artis D. Hoven, who is an internal medicine and infectious disease specialist in Lexington, Kentucky, and is the past president of the American Medical Association. In 2013, she was named one of Modern Healthcare magazine's top 25 women in healthcare, in addition to the 100 most influential people in healthcare. So it's my pleasure to welcome Artis to the podium.
I don't know how to work this computer. This is the problem. There you go. Thank you, Chris. I'm delighted to be here today. It's quite an honor to be
visiting with many of you, meeting many of you for the first time. And I particularly want to send my special thanks to Sir Michael and all of those individuals who convened and planned this meeting, and including the American Medical Association in this. We do thank you very, very much. Since this meeting is taking place in London, I've been thinking about a British billionaire I've heard about recently. I'm sure some of you have as well. His name is Joe Louis, and he has spent millions of dollars in the United States to build a new community near Disney World in Florida. He isn't just building houses on ground that was once vacant, empty fields, but rather his team have conceptualized a community where social needs are met and building it from the ground up. This community, called Lake Nona, has 44 planned miles of paved and unpaved trails. The grade school shares a building with a YMCA fitness and activity center, encouraging wellness. Mr. Lewis even convinced a medical school, a leading children's hospital, and a large veterans hospital to locate there, along with other vital community services. His approach is certainly one way to address many of the social determinants of health. Create a place that offers a wide range of employment, housing, schools, shopping, community services, health care, safe places to exercise, and ready public transportation. But, unfortunately, we cannot build every city anew in this way. Pursuant to Sir Michael's comments about categories yesterday, the United States falls into the do more category, and in fact, I would say do much more category. I must confess that many of my colleagues in the United States haven't a clue about the social determinants of health. When I use that terminology, I then have to explain in great detail, and it's going to take work. So it's energizing to be here to learn what others are doing in their nations and communities to challenge this issue on the social determinants, and to think about the roles physicians and national medical associations can play throughout the world. Particularly interesting to me are opportunities to build clinic-to-community links. Now, probably because I'm a practicing physician, I believe all healthcare is ultimately local, and what happens on the ground in the community is on the front lines in the fight to improve health. While affecting the social determinants is critical to improving population health overall, we also know that impacting individuals in a community can make a difference. At the AMA, we are in the early years of a 10-year journey focused on connecting physicians, patients, and community resources, both in person and virtually. Our goals are to help physicians, care teams, and their patients prevent two of the most devastating health conditions in the United States today, type 2 diabetes and cardiovascular disease. So people say, Artis, why the American Medical Association? These are doctors at home. Why doctors now? And my answer is, why not? These are our patients from every walk of life. We see them in our clinics, our offices, in our emergency departments, in our radiology suites, in our ORs. They are our patients. We are betting that by focusing on prediabetes and hypertension with solutions that tap into resources outside the clinical office, we can establish an organizing force, if you will, that we can build on in the future to address more upstream social determinants of health. So let me begin by describing the health of the American population. Sir Michael argues that health and health inequities tell us how we are doing as a society. Today, 1 in 3 U.S. adults is clinically obese, and in all sectors of our society, obesity is linked to both diabetes and heart disease. More than 29 million people in the U.S., including 11.8 million of our senior citizens, have diabetes. Even more concerning, 86 million adults have prediabetes, most of whom do not even know it. And 70 million adults have hypertension, the #1 risk factor worldwide for death and disability. 30 million of these adults say they have a source of care, and yet their blood pressure is not controlled. What's the missing elixir? We know how to make the diagnosis. We know how to treat it. What are we not doing correctly? So many social determinants of health, as you well know, impact prediabetes and hypertension. Among our minority populations, Native American, African American, and Latinos suffered rates of diabetes or diabetic complications 50 to 100% greater than the general population. And African Americans have the highest blood pressure rate of all U.S. population groups. You can see on this slide the relationship of how diabetes and hypertension affect our white and minority populations, as well as the social determinant of household income. Yet, as I said, both of these chronic diseases affects all parts of our American society. To address diabetes, the AMA is partnering with the YMCA of the U.S., which operates in 10,000 American communities. About 80% of Americans live within 5 miles of a Y. We are encouraging physicians to talk to patients at risk for diabetes or with prediabetes about the consequences of ignoring this treatable condition and refer them to a local evidence-based program like the Y. The YUSA has a behavior modification program based on a model developed by our Federal Center for Disease Control and Prevention, or the CDC, that is shown to reduce the risk of developing type 2 diabetes by 58% in adults with prediabetes and by as much as 71% in those over the age of 60. Very remarkable numbers. Patients in the program work with trained lifestyle coaches and within peer groups to develop healthy eating and physical activity habits and maintain them. Maintain them is key. The Y also creates a feedback loop, and I think for physicians this is the key thing, with the physician's office, so that the patient's progress can be integrated into their care plans. This is a viable, low-cost way for patients to learn to take control of their diets and behavior and improve their health. So far, physician practices in 4 states have participated in our pilot program to fine-tune the details. How is it really going to work? What are the pitfalls that we might face? What are the barriers? Concurrently, we are working to support partner programs that will bring this initiative to underserved individuals in all parts of our nation. With AmeriCares, a medical aid organization, the AMA has announced grants to establish diabetes prevention programs for low-income and uninsured Americans at 7 free and charitable clinics. We will learn how to address the social determinants as part of the disease prevention. And the AMA Foundation has made grants to clinics in locations where social determinants make patients more likely to be at risk for diabetes. Collaborations like these are a first step in reaching more patients in underserved areas where people suffer disproportionately from poor health outcomes associated with prediabetes. 2 of the community clinics, one is in my home state of Kentucky, a rural community health clinic where the local population experiences high rates of poverty and obesity. These people typically lack access to healthy foods and safe places to exercise. About 25% of the clinic's patients are diagnosed with diabetes. An additional 56% meet the criteria for prediabetes. And I would also point out, within this population, there are significant cultural issues that are impacting them. It's historic. It has gone on for decades. And this is going to require us understanding and learning better about how we can, again, effect change. Another clinic, this one in a large Midwestern city, serves an area where up to 78% of the household lives below the U.S. federal poverty level. This area also has the city's highest level of mortality from diabetes and heart disease. So you can see that changing access to programs that do good work actually may improve things, and that is what we are desperately trying to do. As we are able to expand our outreach, it is of utmost importance that we also increase public awareness. As I said earlier, about 86 million US adults have prediabetes, yet 9 out of 10 are unaware that they do. So we are partnering with our CDC to spread awareness and ultimately increase participation by patients who will benefit from programs like the WISE, and to target others who can help shape social determinants, such as employers, insurers, and community-based organizations, and politicians, especially members of the United States Congress. And I could talk offline for hours about many of our challenges. These are the individuals who shape the structural determinants and conditions of daily life that do create our health inequities. Along with the American Diabetes Association and YUSA, the AMA has been advocating for our Congress to support the Medicare Diabetes Prevention Act, Medicare, the health insurance coverage for our seniors. This legislation would cover costs for American seniors to take part in the CDC's diabetes prevention programs. Right now, this is being done with grant money. We want it to be paid for as part of delivering health care. Millions more Americans could get help they need to improve their lifestyles and live longer, more productive lives. And we know that we could save in our country $1.3 billion over the next decade. Let me turn briefly to the other AMA initiative on cardiovascular disease. In the US, heart disease causes a heart attack every 34 seconds and a death every minute. The AMA is attacking this problem in partnership with 2 research centers within Johns Hopkins University, including the Johns Hopkins Center to Eliminate Cardiovascular Health Disparities. Our goal is to find clear strategies and resources physicians can use to help their patients with high blood pressure. Physicians in our pilot programs have taken the lead in developing evidence-based tools and recommendations to improve blood pressure control, including very important steps towards creating clinical community linkages. We know that more frequent blood pressure measurement and measurement away from the doctor's office are important methods to increase control. And we see community partnerships as a significant step toward affecting the control of the hypertension and letting us understand better the role of the social determinants. As our doctors make connections with schools, retail outlets where medicines are delivered, pharmacies, community programs and the like, we're going to become more comfortable that we can begin to change many of the determinants and look at the way we are improving our health outcomes. We are also addressing other ways at the AMA to affect social determinants, and one of them is to provide more minority physicians. This came up yesterday a bit in our discussion. My country has a discouraging history of not being able to make health care accessible to minority groups, whether it's because of lack of insurance, limited access, or even, sadly, racism. And we do not have enough minority physicians. Today, African Americans, Hispanics, and Native Americans make up 25% of the United States population, but only 6% of doctors come from those groups. Encouraging more minorities to become physicians is a critical step toward changing this untenable situation. Research shows minority physicians tend to be more likely to serve in minority communities, as we all know. Minority physicians are far more likely to understand the culture and expectations of our patients, and they want to get their care from someone who looks like them, who understands them and their particular needs. We have scholarships making medical education more possible for minority students. And we are supporting at the AMA many undertakings that equip our broader physician population to better serve those most affected by poor social determinants. One of the other things we're doing right now is accelerating change in medical education. The United States has been talking for decades about how we needed to change medical education. So we finally at the AMA decided to put our money where our mouth was and providing funding for grants to now 11 medical schools in the United States to redesign medical education for the 21st century. And we've already started educating our students about the social determinants of health. At Pennsylvania State University, first-year medical students spend time with patients, helping them navigate the many interactions the U.S. healthcare system requires, learning team care, learning to understand from the nutritionists, the social workers, bringing into focus the social determinants affecting the patient's care. So in conclusion, we know at the AMA and at the United States we can't change healthcare overnight, and we can't cure diabetes or hypertension with 2 office visits. We can't do it alone. It takes teamwork. But we're working together collaboratively with other groups across our country, and as I said before, all healthcare is local, and I feel it, and we all feel it. Only progress is going to be made when we take it to the place where we live, we work, and we play. Thank you very much.
Well, thank you very much, Artis. And the final speaker in our first batch is Dr. Miguel Jorge, who is an associate professor of psychiatry at the Federal University of Sao Paulo, where he is currently chair of the University Research Ethics Committee. He's also a member of the World Health Organization panel of experts in mental health and substance abuse. Miguel.
Well, I thanked Sir Michael yesterday for this opportunity, and I want to also thank some of the people in the organizing because of the help with logistics here, and I was referring to Jenny, Patricia, Karen, and Matilda, among others. Thank you very much for your help. The theme that was assigned to me was clinical interventions in the Brazilian context, and I will give you a quick review of the Brazilian context first. We are experiencing a rapid process of urbanization. There was a shift in our economically active population from agriculture to services in the last decades. Our GDP per capita is growing. It grew 5.5 times in the last 50 years, but our biggest problem is the income distribution, which is still a big problem for us. Our Gini coefficient for the 2 years ago was 0.547, and we are not very well placed also in human development. The HDE index was 0.744. Illiteracy is decreasing in the country over the years, but there is a significant regional difference. For example, in the south part of the country, the richest part of the country, illiteracy reaches 7.6%, and it's 3 times more in the northeastern part of Brazil. Child mortality is decreasing, and life expectancy is increasing. But again, regional difference is dropping, but are very much significant. There is an inverse relationship between the mother's education and child mortality. The higher years of schooling the mother has, the lower the mortality rate for children under 5 years of age. As usual, child mortality is higher for the most underprivileged among the population. On regards of sanitation and water supply, we are also improving the conditions of the country, but again, there are important regional differences among different parts of the country. Internet use is more or less the same. We have a big access. About half of the population now has access to internet, but this depends on the educational level, income, and the place where people live. On regards of nutrition and weight, as far as is happening in some other countries in the world, there is a transition from standards based on cereal, grains, roots, and tubers to fats and sugar. And because of this, we are also being an obese country. About half of our population is above the regular weight, and around 15% 6 years ago were considered obese. I didn't find any updated number on obesity, but we know that is growing very much. There are marked social inequalities in mother and child health. The poor always show a less favorable situation in terms of prenatal care, birth weight, exclusive breastfeeding, immunizations, preventive medical care, morbidity, malnutrition, micronutrients deficiencies, cognitive development, and consequently mortality. The few indicators that are worse among richer mothers and child health include higher cesarean birth rates, overweight and obesity rates, and the use of oral rehydration therapy for diarrhea. On regards of alcohol consumption, data from the government showed that half of the population used alcoholic beverages last year, which used alcoholic beverage in 2012. And this is 62% among men and 39% among women. 16% of the population presented harmful use, and around 7% were considered alcohol dependents. Again, more prevalent in men than in women. The number of people who drinks at least once a week was 54%, but it grew 20% in the last 6 years, from 2006 to 2012. And there are also regional differences in Brazil. On regards of tobacco, around 11% of the Brazilian population are now regular smokers, with a significant reduction in the last decades. But the lower the income, the lower the reduction. Women with up to 4 years of study showed prevalence levels twice as large than those with more years of education. On regards of access to health services, official data from some years ago show that individuals with higher incomes have almost 60% more chances of using health services than those with lower incomes. And individuals with more education have 20% greater chance of using health services than those with less education. And remote areas of Brazil and in the outskirts of the big cities concentrate the poorest populations and also the worst public health infrastructure, and usually less or no physicians. Physicians do not want to work in bad conditions, and if they can avoid that situation, they will. The population age distribution, housing conditions, water supply, and sewerage system are not used by the government to plan for health actions, or sometimes are not well known. Insufficient funds and corruption in their use, even in the health sector, are factors to worsen provision of care and the health condition of the Brazilian population. Some examples of our inequalities on access to health services, considering the percentage of women 25 years old or over that have already had a mammogram ranges from around 25% for those with up to 1 year of school to 68% for those with at least 15 years of study. The same numbers or the same situation can be observed for cervical cancer screening, and also about doctors' visit which is much more available to people with more education than those without much education. Trying to deal with this problem, the Brazilian government created in 1994 a program called Programa de Saúde da Família, the Family Health Program, which is now called the Family Health Strategy and is based in health basic units, or what is similar to primary care centers in Brazil. It's a team composed by different kinds of professionals involving one physician, one nurse, and 2 nursing auxiliaries, and 6 health community agents for every about 1,000 families or 3,000 or 4,000 people. The role of the physician in this team is similar to what the GPs has in the UK. They do clinical consultation, simple surgeries, home visits, and community activities. They care for spontaneous demand on the services. They refer patients to other outpatient services and hospitals when this is necessary, but keep responsibility for following them after that. And they participate in the team permanent educational activities and in the management of these basic supplies of the services. It's a wonderful proposal for clinical interventions dealing with social determinants of health and has many positive aspects. The work in teams allows a larger and integrative view of the patient condition and a multidisciplinary intervention plan. There is a personal and professional gratification for working in a kind of holistic perspective, allow more knowledge on the individual health disease process, and the greater intimacy provides the establishment of a better doctor-patient bond. But there are many problems in the implementation of this strategy. The area usually is too large to be covered by the teams. There are too much people to see, not that one that is set in the papers. There are too much immediate care demands. There are a pressure from the population for specialized medical consultation in contrast to other types of activities like health promotion. There is a lack of reference and counter-reference network of services in the country, and a lack of specialized support and supervision, lack of specific training to work in that conditions, lack of people in the team, and also conflict among the members of the team, a high professional rotation, which jeopardizes the establishment of bonds and increases the demand for eventual immediate care. There is a resistance by the patients to be assisted by non-physicians, difficulties to operate in a non-traditional logic of care, and disappointment with the health service infrastructure and with the social sanitary situation of the area covered, besides low salaries and low professional recognition. This is a report that one physician participating in this strategy has done in a kind of free translation. We can read. Flawed aspects in the Programa de Saúde da Família constitute obstacles to activities related to prevention and health education. The lack of time to prepare such matters for the community, coupled with the lack of teaching materials, impedes these activities. The lack of free hours to coordinate groups, combined with the excessive demand for them. The little valorization of the work of the doctor. Salary is incompatible with the high degree of responsibility, commitment, and dedication of the professional, which explains in part why few competent and prepared professionals are interested in working in the Programa de Saúde da Família. There is also excessive demand and professional wear. In the imaginarium of the Brazilian population, health equals doctors. So there is a pressure to have more doctors available to see the population. And in a kind of electoral measure, in the last 2 years, the Brazilian government creates a program that it calls Mais Médicos, or More Physicians program. Around 11,500 Cuban physicians were imported by the Brazilian government up to December 2014 to provide health care where there is no or few physicians. But the results of this is that, considering all the municipalities that were candidates to receive those physicians involved in the program, now there was 25% less medical consultations after its implementation, and 127 municipalities where those physicians were placed actually has decreased the number of primary care teams after the start of the program. The federal government is paying for those doctors, so the municipalities are saving money and sending their doctors out to do some other things. Something happened here. I'm almost finishing. There are some other problems in this, in this program also, because the difficulties the Mais Médicos physicians will fight will be the same that the Brazilian physicians are facing when they are trying to work in those remote areas or in the outskirts of the cities. But there are some other major problems that I want to just to cite in regards of the Cuban physicians that went to Brazil, because they were not required to revalidate their medical license in the country according to the federal rules about this. They receive 70% less money than other physicians, non-Cubans, participating in the Mais Médicos program. They have their passports retained by the Brazilian government to not travel, and they are not allowed to bring their families to live with them. There is a recent example in my city, in the outskirts of São Paulo, where we have a couple of Cuban physicians, a husband and his wife, and they have 2 little children that are in Brazil, and they were threatened by some kind of monitoring of the Cuban government that if the children do not go back to Cuba, they will be also put out of the program and sent out again back to their country. This is some kind of parallel comment on these problems, but that's okay. It was my last slide. The last one is just the sources that will be available for everybody. And so these are the same difficulties that we physicians in Brazil are experiencing on regards of this. So the problems in the real world about working with social determinants of health in a country as Brazil and many other Latin American countries is real something that constitutes a huge challenge for us to solve. And as a National Medical Association, the problem we have is to convince our physicians to dedicate part of their valuable time to deal with this when they face so many other difficult things to attend. Thank you very much for your attention.
Time for questions. We're doing okay time-wise. We're just a tiny little bit behind, but not much for this kind of a format. We're actually doing pretty well. So let's go and take a few questions. We've heard from the UK, we've heard from the US, we've heard from Brazil, and there's a hand up over here. And while the mic is making its way, let me just give a shout out to the tweeters in the crowd. I count about 12 of them, and you're doing an excellent job capturing the key messages. You can read through the feed and it feels like you're here, I'm sure. I am here, but it feels like I'm here too. Question number 1.
Hi, thank you. I'm Medical Director of Pathway, which is a small charity set up to improve healthcare for homeless people. And my question is for my UK colleagues. What should be the role of public health in challenging government policy which increases health inequalities? We can all think of examples like vulnerable people starving to death as a result of benefit sanctions, but the latest thing announced just yesterday is that our government support for babies and children under 5 who are asylum seekers has been reduced by £16 a week. So an asylum seeker baby will have just £5 a week for nappies, food, clothing, warmth and travel. So our government's policy is driving babies into destitution. What should be the public health perspective on those kinds of decisions?
I think I'm the only UK person left on the panel, so I think I have to respond to that. I mean, I'm not a civil servant, but I work for the NHS. But one of the things I have learned that's important, possibly for your challenge, is that housing is a much more important determinant of health than most health professionals understand. And the way I've learned that is by working with colleagues in local government. So I'm sure wherever you sit in the system, that you will have good colleagues in local government. And certainly in this country, the whole pattern of how housing, specifically social housing, is provided has changed massively over the past 25 years. And in fact, there are regulations in passing through both houses at the moment, which are going to make it worse in terms of the quality of housing. So, I mean, the two things I would say, which are fairly generic responses to your admirable challenge, is one, understand quantifiably and compellingly the influence of poor housing on health and the cost of healthcare. I mean, because the second thing I was going to say was become politically engaged in the reality of how legislation is passed, not just nationally, but locally. And I think there are some incredibly expert people in local government who understand about housing, whose hands are equally tied in the sense that they can see that a lot of bad housing is actually privately owned and privately let. And that's quite different from the social housing picture we had 25 years ago. So first of all, I think doctors know very little about health. Okay, we're trained about disease. I never went to medical school. Did anybody go to medical school and go to a lecture which said these are the causes of health? I didn't. Okay, so secondly, understand the data around housing, and thirdly, get politically engaged via local government colleagues. That's what I'd say.
And we should all adopt the Finnish baby boxes, I think, too. That would be a great step forward. Next question.
Hello, I'm Lucy Jones from Doctors of the World. I just wanted to follow on from Nigel's point. We're an international NGO, but we have programs across Europe and here in the UK to support excluded people to get access to healthcare. And we've had experience of trying to influence government policies where we're concerned about the impact on the health of particularly vulnerable migrants through the Immigration Act. And really just to say that it was a good example of medical associations in the UK supporting civil society organisations to protect the rights of the vulnerable, and that resulted in plans around charging for A&E and also some primary care services to be deferred. But we need continued support on that as we go into a new government, and really calling on people to support those causes where perhaps it's easier because it's more directly related to health services and the impact on health services.
Thank you for that comment. Other questions? In the back? Yes, go ahead, sir.
Hello, thank you. My name is Richard Parrish from the UK. My question is for all of the panel, although it is prompted by David Pencheon's example of the catering manager in Nottingham. And the question is, how do we better use the economic power of the health and other public services? And if I take the example of food, if you think about the amount of food that is purchased and consumed by our hospitals, in our health centres, schools, universities, colleges, professional bodies and medical associations. We have an enormous amount of economic power to change the specifications for food supply. And some of us have been arguing for this for 35 years or more, but how would the panel suggest that we better leverage that economic power to change food supply for the better? Thank you.
Great question. Who would like to tackle that one first?
Oh, and I might just say briefly, this country, the NHS in this country has got a budget of about £110 billion. The direct procurement, that's the buying, is about 20 billion. Okay, so the NHS is the biggest buyer of food in the country, but it's the biggest buyer of pharmaceuticals as well. And in a sense, if you're thinking about waste and quality of care, one of the pieces of data I've never quite managed to elicit, somebody here might know it, is this. This is a magic figure. What percentage of pharmaceuticals made globally around the world end up having a positive therapeutic effect? Does anybody know the answer? I don't think anybody does know the answer, actually. It's probably, don't tweet this, it's probably about 1%, okay? That is an eye-wateringly, I mean, anybody who knows the rules of halves in hypertension will know, shouldn't be surprised by that. But the power of procurement, you're absolutely right. We are very poor at using economic leverage to improve wider social value. And that example I showed you, that is an example of leadership at every level, because that guy, John Hughes, a deputy catering manager, has engaged procurers and said, listen, this is what we want, and we'll draw a line in the sand. Most people in the health sector go for the cheapest, okay, regardless of any other dimension of quality. That we don't cost the social value, we don't value it at all, but in terms of our employment. Healthcare systems around the world are one of the worst employers in the world. You've got to realize that. And that is an example of good organizations doing bad things because they are good. We don't feel we need to treat our staff well. So the way we treat our procurers, we don't leverage it well there, but we don't treat our staff well as well. It's called the paradox of noble organizations, and anybody who's seen it will recognize it very well. So you're absolutely right. Pharmaceuticals, food, even water, I mean, for energy. I mean, you could, the NHS in this country, any health system in any developed country could revolutionize the energy system by saying, we will buy this amount of renewable energy because it's we know that procurement, collaborative procurement for long term has massive leverage. If we got our game together, we could easily do this. The same is true about divestment. The healthcare system, medical associations around the world hold millions of dollars of money, where 25 years ago we divested from tobacco companies. Think of all the undesirable organizations we could send a very powerful message to as medical associations by saying, we will hold a mirror up to ourselves and see who do we invest our pension funds in, who do we invest our assets in. So you're right, procurement is very important, but actually what we do with the system about our investment of pension funds is equally important, and we've been through this before 25 years ago with tobacco, but the other challenges are even bigger today, and we don't use them because we're not skilled procurers, and exactly the same applies to the commissioning of healthcare. We do not commission healthcare well. We commission for activity, not for outcomes. If you commission for health outcomes, you would revolutionize what health systems do. We commission for activity, which is totally the wrong thing to do. We monetize illness, actually, when we should be monetizing health. So there's a very big agenda there, Richard, so it's a great question.
Thank you, David. Artis has a response to the questioner as well.
I'm going to take a slightly different tact, and it's probably a 30,000-foot view on this. In the United States, physicians in advocacy, when we spend time with our legislators, be they at the state level or at the federal level, as we start talking about health care and trying to substitute the term health, we begin chatting with them about how we can diminish waste of dollars, particularly in overuse of procedures and tests and drugs, how much money can actually be saved, and how we can improve the quality of the care that we render in that setting, and that ultimately we're going to see a decrease in cost and an increase in health. And in fact, what gets their attention, our members of Congress and state legislatures, is that in fact we are saving them money in the process. It's a long learning curve for some of them, unfortunately, but in roles of advocacy, this is one of the ways that we do it in talking about the best way to deliver the care to deliver good health.
Well, thank you, Artis. We're going to take one more question before moving to our next couple of speakers, and this gentleman here on the side had his hand up first, and I apologize for not getting to everybody, but we'll go with just one more for now.
Hello, I wanted to re-emphasize some of the points that David raised. I'm here because of a personal academic interest, but in my day job, I work for Roche Diagnostics, an in vitro diagnostics company. And as part of my day job, I've been trying to alert colleagues to some of the initiatives that actually we really should be engaging with. And one of the things I did about 18 months ago was to try and alert them to the Public Services Social Value Act 2012. Now, this is a piece of legislation that came in with very little comment, very little opposition, and it is an act to require public authorities to have regard to economic, social, and environmental well-being in connection with public service contracts and for related purposes. I worked to try and ensure that as a company, we recognise the potential of that, and so that in the expectation that health commissioners, foundation trusts would be saying to us and challenging us, how are you going to help us fulfil the requirements of that legislation? Without going into details, I can honestly say not a single contract that we have entered into, any tender that we have sought to win, has ever raised it as a stipulation, yet it is a legal requirement, and therefore I fully endorse what David's been saying, and there has to be, it's not just about government and legislation, it has to be about attitude.
Thank you very much for that comment. Okay, folks, thanks very much to the speakers for some really great presentations, to the crowd for a very lively discussion. I'll excuse our previous speakers with thanks on your behalf to them, and I'll invite to the